From theheart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, this is Bob Harrington on Medscape Cardiology on theheart.org. I always like to do a show from the Heart Association meetings, or the American College meetings, the European meetings, because it gives me a chance to grab some great guests and talk about timely topics. Sometimes it's what has been presented in the meetings. This time I want to talk about a recent paper. And the recent paper was a state-of-the-art review in JACC, where they really called into question what I'll call the ST elevation MI paradigm. Now, what I mean by that, it's using the elevation on the EKG as a mechanism by which we make decisions. Going to the cath lab, not going to the cath lab. Going to the cath lab immediately, going to the cath lab in a more delayed fashion. Well, they call that into question, and they say, hey, there's more to it than just ST elevation. What you're really trying to figure out, is there an occluded artery? So we're going to walk through some of the history of how we got there, what people think of this premise, and then with my guests really talk about what's the future. So two great guests today, two good friends. Mike Gibson from Baim Institute, where he's the CEO and a professor of medicine at Harvard, and an interventional cardiologist at Beth Israel Lahey. Next to him is Manesh Patel, cardiologist, interventional cardiologist at Duke University, where he's also the chief of the cardiovascular medicine division. So Mike, Manesh, thanks for joining us.
Thanks for having us.
We should have gotten all this stuff pre-taping on screen,
Yeah.
But let me go ahead and start with the easy one, Mike. You think this is a worthwhile topic to dive into, and do you think it's timely?
It's definitely worthwhile diving into. I mean, we've come a long way since Q waves at discharge as a metric. We realized that time is muscle, so we moved up to STEMI, but it really is time to move beyond that. We know that in something we published, if you have ST depression in the anterior precordium, third to half the time the artery's closed.
Posterior infarct.
It's a posterior infarct.
Yeah.
And so we're sitting on that. In that study, 29 hours in the Timmy Triton study for people to get to the cath lab. No one was there quicker than 9 hours. So we're sitting on a lot of closed arteries with this ST elevation.
And that's what these authors brought up as the central premise, is
Right.
that if you just go by the classical ST elevation as the diagnostic tool, you're going to miss occluded arteries.
Absolutely.
And you're going to miss a fair bit of them.
Yeah, the posteriors.
The posteriors, you're going to miss ones where maybe the ST was up, it's down. You and I have talked over the years a lot about cyclic flow variation.
Large branches.
Branches.
Ramus infarcts are often seen that way, maybe sometimes depending on the right coronary territory. But again, it's really hard because we're using ECG to try to figure out what's going on the angiogram.
Well, when I first read the article, the other thing I thought about is, wow, we actually didn't just develop the paradigm, if you will, to diagnose ST elevation. We really tried to give a diagnosis to the others, which used to be called non-Q wave infarction and unstable angina. And I always would say, well, why are we giving a diagnosis like 3 days after the event happened? How about more acute? And that's where the whole, in the early 90s, acute coronary syndromes with and without ST elevation.
But it did us a bit of a disservice. I mean, we did do trials on non-ST elevation MIs, treating them like a primary angioplasty. Didn't see a lot of benefit, but non-ST elevation MI is a bit of a wastebasket. I mean, you have closed arteries, you have open arteries, you have
normal arteries.
You have normal arteries with a supply-demand mismatch. So, we have to do better in terms of identifying the occluded arteries that really warrant the timely intervention.
I would say that's right. I would say the other thing clinically is it's the occluded artery, but really what we're really trying to figure out is somebody had a plaque rupture. As you guys and others have said, it's occluded sometimes, then it's open sometimes.
Yep.
So it's a dynamic process too. So we would see in this day and age that we have to move away from ST elevation, just like we have to move away by a single troponin value to say, oh, somebody's having a heart attack, to say it's a clinical issue. In our place, we often talk about, yes, of course we want to change a threshold to do something, but what is the information you need to go do something for them?
Well, and it's not just plaque rupture, it's also plaque erosion. And it drives me insane in cath conference because everyone's always looking for the tightest artery.
Right,
they go and
right.
intervene the tightest artery. You're like, well, what about that circumflex over with that clot over there?
Yeah,
It's open.
yeah.
Well, it's not that tight.
Well, and remember, we knew from studies a long time ago that the artery that appears to be the infarct artery is often not the only one with disrupted plaque.
Right.
That people have looked at the angiogram and they say, oh, you have an LAD infarct, but wait a minute, there's hot-looking plaque over here in the circumflex as well.
Yeah, it's quite complicated, right? We've actually also evolved from saying when you have shock, open everything, to only open the artery that you think's causing it, to where now when you have STEMI or acute MI, we're saying treat the IRA, but maybe also treat the others. I believe because we're having this confusion and patients do benefit from getting all the arteries.
Well, Manesh, let me go back because you have run a lot of important committees for the AHA and the ACC, appropriate use, you've been on guidelines. And one of the things that ST Elevation has really done is helped us in the quality front.
Yes.
How long did it take you to get from door to balloon? How long did it take you to get from home to diagnosis? There's also, for you who have run a cath lab, what about calling in your colleagues in the middle of the night for false
alarm, right? And you know, I have to say the work done by many others in this space has been amazing. The ST Elevation paradigm has helped us take better care of acute MI. The AMI management strategy, you know, the lifeline strategy of time, door to balloon, get to that, reduced a threshold that I have to be quite frank was much higher. When I was a fellow, as you know, it would be a lot to bring in the cath lab.
Well, I'm also smiling because I'm thinking of our colleagues.
Yeah, that's right. There might have been some colleagues. It was a lot to bring people into the cath lab, even when they had ST elevation. So we started with that. Then we had, even though we knew time is muscle. So I think we've changed that paradigm. And when we've changed that paradigm, that's important. But even in changing that paradigm, sometimes you swing too much one way or the other. So the threshold to go to the cath lab shouldn't be very significant. You still need a clinical diagnosis. And I do say this when we orient our interventional fellows. You call me in, tell me one of the 5 reasons I'm coming in. Is the artery closed is the first one, right? And if you think the artery is closed, it doesn't matter just if it's DCT,
just come in.
Clinical symptoms not. Call me because we don't want to have the 9 to 25 hour wait for somebody who has a circumflex or a ramus. And you might be wrong sometimes, but that's why we're learning. That's what the whole fellowship or training our life's about. So that's one of the key steps, I think, for all of us.
Tell us the other 4.
Well, the other ones are, is somebody need a pericardial effusion tapped? Their hypotension, that's important to do. Sometimes it's a device, a balloon pump. Right?
Yeah.
And the last one is you're shooting course because there's a donation of the heart or something else. Those are usually the 5 clinical ones. But the 5th one, after that, if you don't tell me one of those 5, you say, I don't know what's going on. That slows me down. Now I'm thinking. Otherwise, you tell me one of those 5, I'm like, sounds good. You have a plan. I'm coming in. I don't have to hear all the risk factors.
Yeah.
I just want to know this is the patient's age, this is the blood pressure.
Just good practical stuff in the middle of the night. Mike, how about up in Boston? Is the false alarm issue still a big deal, or are people willing to come in based on these other criteria clinically?
Depends what you mean by a big deal. It's still prevalent. There's a fairly high 30 to 40% false alarm rate. But that term makes me nervous, having looked at all those angiograms in the 90s.
Yeah, I don't know if anybody's looked at more angiograms.
No,
that's right.
So, we'd look at 45 minutes, 60 minutes, 75 minutes, waiting until that beautiful 90-minute endpoint, and the artery is winking and blinking. It's opening and closing. So when someone says, oh, yeah, they don't have any, the artery is open, you're like, well, 5 minutes earlier it's probably closed. So I'm just uncomfortable with another false positive. I don't think that's
so. You like
false positive,
as Manesh is saying, and what this review article says, you have to put the whole context together.
Yeah. And we have made tremendous strides, major public health victories on the door to balloon time. Probably one of the bigger success stories in cardiology. On the other hand, we have failed completely on symptom to door time. I mean, in the 80s, the 90s, now in our current era, it's 2.25 hours.
You know what it was in Gusto 1 back in 1990 to 93? 2-point-something hours.
Yeah,
Yeah,
it's over 2
2.25
hours
hours.
for many years. And I would say that the big value proposition we've seen is we've reduced some metrics and statewide and regional mortality by going door to balloon, but that time of symptom onset is still bad. And I also think that, and as an interventionist for many years, we said, can it be door to sheath? Because you want to take the pressure off to let them make the decision once they see the vessel to say, instead of just going for the tightest, which one's the clown, right? So there is a little bit of tension. We often also say, of course you can be fast. For its role, it got us there faster. But I'll say, it should be door to think. Now I have a moment to think once I've seen the vessels.
We need to move the therapy into the home, and we need to move the diagnosis upstream into the home. So that's where some of our efforts are focused. A couple of them, for instance, I published a paper last year looking at single lead.
Obtained from a device? Okay.
And the truth standard was an occluded artery on the angiogram, vast hundreds of thousands of patients in Brazil, and then we had about a 90% accuracy of detecting a closed artery. There's other technologies coming along that don't use traditional ST elevation. they use vector cardiography. And that's a big advantage because it shows you, is there a posterior
And you and I have been involved in some of those.
Yes, heart beam technology. So we're getting there. I think it's going to take home-based monitoring. The other thing is continuous monitoring. So I had an implantable device, 17 years studying this. And we did get people to the hospital in 30 minutes, you know, if this thing went off. Now, what we also learned, people thought, oh my gosh, you're going to dramatically increase the flow through the cath lab. Actually, no. We actually, you know, 1 out of 6 people had a true heart attack, and a lot of those just by symptoms.
Yeah.
They were on the rocket sled to the cath lab, but this actually changed things. And finally, I'll say 5% of heart attacks were asymptomatic that we detected.
That you picked up.
Wow.
That we picked up.
Wow.
And, you know, out of 1,000 patients, we had about 45 people who had a silent MI. The thing's going off. Everyone's like, what is this thing?
Yeah.
And they bring them to the lab, they had a closed artery.
Well, let me ask you, Manesh, because you've been involved, along with the both of us, in a lot of the trials of non-ST elevation. And there's been randomized trials. That
That's
have
what I was going to say. You know, we've
taken
studied
people earlier, later.
Yeah, and we'll just say that the sweet spot for us seems like going earlier is generally better, but you don't have to go as early as we do with a STEMI, right? And I think that's partly because of the heterogeneity of it. So whether it's the time trial or others, we've shown, and I like to say this, but it's not fully evidence-based, but generally, not a lot of good stuff happens from waiting. Now, you have resources, you don't want to take a bunch of people till you clinically know what's going on. But for people where there's ongoing chest pain, true feeling of there's an MI, then going sooner is faster. In the non-ST elevation MI trials, it looks like going sooner, meaning within the first 24 hours, versus later, meaning 3 to 5 days, was better.
Yeah,
And then there's been a few trials where they tried to go in the first few hours. There we didn't see a huge difference.
You know, except in that group where the GRACE score was really high, right?
Yes,
That's right. The trial out of McMaster, they stratified people based on their GRACE score. And you did benefit going early, maybe not that quickly.
Yeah, no, you get benefit going earlier, and we risk stratify whether it was the GRACE score or TIMI risk score, other scores, you can go sooner. And I think one of the things we think about all the time is this is going to just get much more personalized, right? We're going to get more information for that patient. As Mike's saying, whether the diagnosis is upstream because we've got some monitor saying this person's having an event, to that person now in the hospital is going to have a variety of other data streams, I suspect, to say they're much higher risk than you think. One of the things we often see is risk miscalculation by the people, whether they're coming to the lab saying, oh, this person's not going to be too sick because they're younger, or they're actually having a big event versus other features.
Well, let's talk about something I saw yesterday. There was a group from Europe that did what you did, which is they took a bunch of angiograms with occluded artery and used that as the central truth, had the associated EKGs, fed that all into the machine using large language models, and came up with a ability to predict whether or not you'd have occluded artery. And all sorts of stuff is being missed without looking at just ST elevation. Practical to think about starting to incorporate these into our ambulances, our emergency departments?
I think so. You know, we had a piece we recently wrote called Translating AI for the Clinician. And I think the thing I would say about this
was the JAMA article.
Yeah, the thing I would say about this is, what's the indication? Because doctors are going to ignore new AI tools unless you say, here's the indication, we randomized people, showed them how to do it, just like any other diagnostic thing. So for this tool, for example, I love the idea, and I would say, randomize people to turning that on or off and seeing if more people go and get an occluded artery find. I suspect it will, but
let's do the study just like we would with
and then
any
my
other.
biggest fear is, and I say this about AI tools in general, doctors that know how to use it will be better than doctors that don't. But you got to get people to use it.
There's also tremendous advances in biomarkers now.
Yeah.
There's going to be a troponin, you spit, and you know.
This
and they
troponin gets picked up in sweat.
in sweat.
Oh my gosh, this is like a nightmare for me in the ER, man. Sweat troponins? What are you guys up to?
Yeah, they put it. I don't know if it's sweat
They
or
put a patch on it,
they put a device on the skin.
It turns. Well, there's also now Binha AI has a ring that wears that detects your hemoglobin, A1C, glucose, potassium, and I'm sure we're going to get to a troponin here.
Yeah.
So you're going to couple a wearable with an alarm with
a biomarker
in the home that triggers some home therapy or gets the ambulance.
I mean, it's awesome if it works well, and I think it will if we can get the right sort of testing. That's what I think will happen. But the technology's coming to where we're going to know a lot more about people, or we're going to be able to predict based on what we know about them what's going on.
Yeah.
But here's the paradox.
That's exactly right.
The better you get at this diagnosis in the home, and the better you get at pre-hospital treatment, they show up to the cath lab and they have an open artery. And then you say, oh,
I'm not going to do that
positive.
again.
A false positive.
Right.
That's
No.
why I said that's why you need the studies, because otherwise you're going to have just so called
Well, because you have to
recency
test
bias.
the strategy, right?
The
You have to see
strategy.
if the strategy is
Correct.
of doing this is better than the strategy of doing what we usually do.
But we're trying to abort an MI.
Yeah.
And if you have aborted the MI, you don't get credit for it. So that's the paradox.
Mike, let's take you're doing the trial of the injectable 2B3 inhibitor. What triggers the patient or the EMT using the injectable 2B3?
They get a 12 lead in the field.
Okay.
And when they
so it's
see
not the
us-
patient doing it at
No,
home. Okay.
but when the ambulance shows up, they consent them. And then if they have ST elevation, they go ahead and give the drug subcutaneously.
They get randomized.
They get randomized, and they give the drug subcutaneously, bring them into the hospital.
It's a big trial.
2,500 patients, we're 2,000 patients in. So
We'll know the answer
We'll
soon.
know the answer soon.
Which would be it's an interesting way to think about
But
it. Right?
another fascinating thing is the FDA finally agreed that infarct size is clinically relevant.
Yeah, we've been spending years
We've
trying to
spent
get to that.
decades. We've
decades
gotten
on
there,
that.
we've gotten
Whether it
there.
was concerted MRI data, SPEC data,
But so
area
it's
under the curve.
death, MI, stroke, stent thrombosis, hospitalization for heart failure, and then the bottom of the win ratio is
Infarct
do you have
size.
a tenfold elevation in your troponin?
So really trying to incorporate everything that's going
Correct.
on, including a biologic marker.
Correct.
Yeah,
When-
and I think in addition to this, we're also doing a study with an injectable P2Y12. Patients can use at home if they're having chest pain. So we're moving therapies
Using
closer.
the same win ratio.
Using the same win ratio. So the idea that if you can identify sooner, you'll have therapies at home sooner will be really important.
So first we have to figure out if we can identify it.
That's
So-
right. And
so,
this closed artery eye is a great way of thinking about it for the cath lab, but it's also going to be a great way we think about it as we have patients with maybe more information with continuous monitoring.
So I think we're all three of us are agreeing that this article that got us thinking about this topic, it's taking a lot of thoughts that have evolved over the last 30 years to really trying to put it forefront of how do we use all available information to make the best decisions, and then how do we empower patients to get involved in their own therapy while they're making their way to the hospitals. Is that a reasonable summary?
Yeah, I totally agree. I'd say back to basics for us in the practice right now is making sure you're still making a clinical decision. You still have good EKG reading skills, and you're still thinking about the things you guys all say, posterior currents, vectors. But additionally, one can imagine that the article is really pushing us to say, how do we change the practice and get it into the home?
Anything else to add, Mike?
Well, we've always said, non-STEMIs have as bad of outcomes as STEMIs. But that, again, is the heterogeneity of the non-STEMI coming through. If you look at the non-STEMIs that have a closed artery, there's an 8.9% rate of adverse events. But if they have an open artery, there's 2.6% rate. So they, of course, have more comorbidities. But I think we've got to maybe refocus our classification of these non-STEMIs. And this occluded vessel paradigm
Maybe helps us think about that.
it helps us when we're doing trials to say not all non-STEMIs are the same.
Yeah.
We need non-STEMIs that have an occluded vessel to really enrich.
Manesh, I'm sure, has heard me say this over the years, that I have always thought and tried to teach residents and fellows that it's the non-ST elevation cohort that in many ways is more interesting because it's harder to figure out because you've got everything from really bad disease to normal arteries. They're not the same. And then there's the issue that while their acute risk may not be as high, their delayed risk is really high. And maybe, and that's a whole other area of identifying the non-STEMI patient so that you can treat them down the road.
Yeah, I think the non-STEMI is much more of a disease of aging. STEMIs are often younger, single vessel. Not to say they can't happen later and more complicated. There's huge overlap, but when you get a large non-STEMI population, much more comorbidity, much older.
But we have changed the biology of STEMI. I
Yeah.
mean, when you and I were young, you're younger than us. When we were younger, every day, Bob, you knew there'd be 3 or 4 STEMIs coming in. And
Manesh was a fellow then. He remembers.
I
you remember
Yes.
that?
Yeah.
Okay, so, but that's not happening now.
No.
With statins, aspirin, all the
And now
therapies,
GLPs,
all the
SGLT2, yeah.
We've changed about, we may see one every other day or something. It's really changed.
It's much more
dramatically.
what we see is the other side, non-STEMIs
Yeah.
and much older. In our lab, we are stenting and taking care of patients that are in their 80s routinely.
Yeah.
But
People with
probably more-
multi-vessel proximal left main, not just in the ACS scenario, burden
But
of
complex
disease,
coronary
complex
disease.
coronary
Yeah.
disease where surgery is really complicated. What are we going to do percutaneous?
But maybe a fair amount of plaque erosion
Yeah.
that we're not seeing
That's right.
as much on the angiogram and less plaque rupture
Yes.
with visible thrombus.
More-
We've changed the
more
biology.
burden.
More burden, yeah.
All right, I'm going to have you both back to talk about the diffuseness of the disease, the changing paradigms of using things like CT angio to look at plaque before you go to the lab. better characterization of plaques so that you can decide upon both the medical interventional strategies when you get into the lab, and making the lab a more high-yield environment as opposed to going in there. What did you say? You don't know what's going on, so we'll take them to the cath lab.
Yeah, right. I often say, if you don't know, let's go figure it out.
Thanks for joining us. It's been a fabulous discussion, and I want to thank you, the audience, for joining us. Let us know if you like the show. Give us a like, write us a comment, subscribe, because it's really what you tell us as an audience that really defines the kind of topics we're going to address in the future. So thanks for joining us, and thank you both for joining us.
Thanks for having us, Bob.